chat with your state of licensure and EMS license number so we can record that. If you have questions during the presentation, feel free to shoot them in the Q&A or the chat. We'll keep track of both of those and try to answer them as we go. And if not, we'll get to them at the end. Additionally, if you see the need for a certificate for out of state, please send me an email and we'll get that to you at some point. Other than that, we'll post in a evaluation at the end for you to complete, and we appreciate you for attending. Dr. Minicello.
Perfect. Sounds good. And yeah, definitely I'm a ask question as we go person. So don't be afraid to drop in anything into the chat. This is admittedly a very large topic. Like there are specialists in the world that spend like 2 to 3 years of fellowship just to dive into heart failure. So trying to cover heart failure in 1 hour is a big task, but nonetheless, here we go. So I don't get paid anything special to do these. So a case just to kind of frame our discussion. I think this will likely be a type of patient that hopefully everyone here has seen. Even if you are new into this job, within a week or so, I imagine you would see this type of patient. But you get called to a male in their 60s who's having shortness of breath. They're unable to speak in full sentences. They're tripoding. This is your initial set of vitals, noting that they are quite hypertensive. They're a little tachycardic. They're certainly tachypnic. They're hypoxic. And temperatures like maybe slightly elevated, but they don't really have a fever. Real quick for people who are also throwing in licenses, but just throw down a couple thoughts of what's on the differential, recognizing that this is a heart failure talk and I'm probably going to diagnose this person with heart failure, but what else does this look like? That's okay. I won't pause for too long. I think one of the biggest questions for folks that come in, yeah, PE is a good thought. I think one of the things that comes in for folks like this, the big question is always, am I going the direction of CHF or am I going the direction of COPD and asthma? My goal with this talk is to try and help give you ways to tease out the two. And then I'm going to make a big push to say that when there is uncertainty still between the two, that there's a common pathway that treats both things. All right, so our objectives, we're going to go through just a little bit about the epidemiology and prevalence of CHF. We're going to do a little pathophysiology, which is where I love to nerd out. But I think understanding how a disease works make it that much easier to understand how to treat said disease. Doing a little review of signs and symptoms, different things you can do to pick up on maybe some subtle cues to guide you which direction. Talking about ways to then distinguish CHF from other causes of shortness of breath. And then ultimately, what are some great treatment options we have and why do they work? So a little to the epidemiology piece. So if we look at heart failure across the US, there are just about 7 million people that carry a diagnosis of heart failure, which means there's probably at least another million of the patients that you go to where you say, what medical problems do you have? And they say none. And the answer to that is because they haven't seen a physician in 10 plus years. So there are definitely the folks that carry this diagnosis that just don't actually have it diagnosed. Looking nationally at hospitalizations, there are about 1 million hospitalizations in the US annually that are attributed to CHF, whether that's a heart failure exacerbation or they're just being diagnosed with it for the first time. And so it is certainly ubiquitous. Like you are going to come across this for sure. And then this number bounces around, but most recently it is currently the leading cause of admission for adults over 65 years old is heart failure. So again, this is why it's so important for us to talk about this. Like it's fun to do the niche high acuity things are fun to talk about and learn about, but it's also important to talk about the things that we're going to see every single day. These folks are sick and they can get sick often. About 20% of them, when they're admitted to the hospital, are going to come back to the hospital within 30 days. And then the cost to the healthcare system between pre-hospital costs, in-hospital costs, and all the comorbidities that follow, heart failure alone costs the healthcare system over $30 billion a year. So it is by no means an insignificant diagnosis. So what puts people at risk to develop heart failure? So this is especially for folks where you're suspecting heart failure, but they don't have a known diagnosis. But if they have a history of high blood pressure, if they have coronary artery disease, if they've had a heart attack before and have some scarring of their heart, diabetes causes heart damage over time, obesity causes stress on the heart over time, smoking causes just about anything. CKD, chronic kidney disease, we'll talk a little more on pathophysiology, how the kidneys and the heart are connected. If you have something like mitral regurgitation and a bad heart valve, the heart can't work normally and ultimately leads to pump failure. Atrial fibrillation or flutter, when you have arrhythmias, puts stress on the heart. And then COPD and pulmonary hypertension will specifically get into right heart failure, and having bad pulmonary disease causes the right side of the heart to fail. So that's what makes you have CHF in general. But then what precipitates these acute exacerbations? Like what makes someone now symptomatic enough that they're calling for help? One of the leading pieces is medication noncompliance. And so someone is either misunderstanding how to take their medications or has just chosen not to take their medications. Or unfortunately, we see a number of people who have insurance issues and their medications are no longer covered. And they come into the hospital, which costs them far more than if their insurance just paid for their meds in the first place. But I am not here to give a politics talk today. Um, Dietary pieces. There's good data that shows there are massive spikes in CHF admissions the Monday after Thanksgiving because people eat their turkey dinner and all their salty sides for multiple days through the weekend with their Thanksgiving leftovers. And by Monday, they've added so much salt and water to their body that they come in with their CHF exacerbations. Infection can tip over that scale. Having a heart attack or an NSTEMI will tip over that scale. If you have someone that all of a sudden goes into AFib with RVR, that will tip over that scale. Someone that goes into kidney failure and starts retaining more fluid will tip over that scale. And then if you go into like a significant hypertensive crisis, or if you do develop a PE, that's a big enough insult to cause a CHF exacerbation. This is where I get to say you can take off your EMS hat for a minute and put on your firefighter hat, because the heart really is just a two-part pump. It is two pumps that hopefully are working in unison together. But when they're not working in unison together, or if one individual pump fails, you're going to have problems. So when we, in a second, look at some of the anatomy and physiology, when we talk about left-sided heart failure, we're specifically talking about the left ventricle is not working. So your body is not pumping blood out to the rest of the body the way it should be. When we talk about right-sided heart failure, we're specifically talking about the right ventricle not pumping blood to the lungs effectively. Biventricular heart failure means both of those pumps are not working. And then some other terminology you might hear is someone mentioning diastolic heart failure or systolic heart failure. The newer hip lingo nowadays for these are HFpEF and HFrEF, meaning heart failure with preserved ejection fraction, meaning the heart's squeezing normally, but it's that diastole, it's that the heart is not resting appropriately is the problem. Whereas HFrEF, that reduced ejection fraction, is your systolic heart failure, and the heart's not pumping forward the way it's supposed to. This is less important. I would not memorize this chart, but I just give this as an acknowledgement that there are two different systems to classify someone's heart failure. So if someone ever tells you I have advanced stage or end stage heart failure, there's a scoring system put out by the American Heart Association that stages it, and it's based on how much symptoms you have on top of your structural heart disease. And then there's the New York Heart Association classification scale that looks more about the symptom piece and how functional you are or are not. And these ultimately are what dictate what therapies and treatment you're eligible for. All right, pathophysiology. This is where I get to nerd out a little bit. All right, this is a decent view of the heart. It's really hard to show the whole heart in any one single cross section. But I want to just take a minute and make sure we're all on board with the anatomy of the heart. So you have blood returning to the heart into the right atrium, comes either from the arms and the head into the superior vena cava, or up from the legs and the abdomen into the inferior vena cava, and all the blood's going to return to your right atrium. The right atrium then goes through your tricuspid valve, because there are 3 cusps, tricuspid valve into the right ventricle, and the right ventricle then goes out the pulmonary artery, because it's away from the body, even though it's blue, goes out the pulmonary artery. This is a mislabeled diagram. That's not great. Out the pulmonary artery to the lungs. At the lungs, you then have gas exchange, great, and you come back to the left atrium with oxygenated blood. You then go through your mitral valve, and your mitral valve is also called the bicuspid valve because there are 2 cusps into the left ventricle, and then left ventricle out the aorta to the rest of the body. Now, a couple of the places that we're going to talk about where this system goes wrong is, as you can see a little bit here, for the normal happy heart, the left ventricle is going to have thicker muscle than the right ventricle because the left side of the heart is doing much more work than the right side of the heart. The left side of the heart has to push against the pressure that is built up in the aorta, and that is the blood pressure that your body sees. So at opening, the ideal of 120 millimeters of mercury, and at diastole, 70 to 80 millimeters of mercury. Whereas the right ventricle just has to push against the pressure inside that pulmonary system, which is much more on the scale of 10 to 20 millimeters of mercury. So when the average person with normal anatomy and physiology, the right side of the heart does not need to be nearly as strong as the left side of the heart. But as we'll see, as you start to have failure in either sides of the heart, you're going to have thickening of the heart asymmetrically, which looks like this. So here in the top, this is a cross section of a mostly normal adult heart with looking on the left side. This is what it would look like. This is slightly thickened, but that looks okay. Whereas here you have a giant right ventricle that is a result of right-sided heart failure. Here, hopefully it doesn't take much convincing. This is an incredibly thickened left ventricle. There's almost no space left inside this ventricle for blood to go, and you have a thickened right ventricle. This is very much your hypertrophic heart failure, I'm working way too hard heart. And then as you can see, this would be a vicious cycle of the less blood that's inside the heart of the heart's going to have to work to get enough blood flow going around. And this is why this spirals into such a unfortunate disease process for folks. If we think more to the different pieces of the heart, and this is how we can modify and adjust the heart, is we got to think about these components here. So your stroke volume is made up of 3 pieces. So stroke volume as a concept is how much blood is coming out with each heartbeat. So per heartbeat, the volume of blood that gets pushed out to move round and round. And there are 3 things that help determine how much blood goes out with each heartbeat. The first thing is preload. Preload is how full is the tank before the heart then squeezes. So preload is the ability for those atria to squeeze blood down into that ventricle to get the ventricle stretched out and ready to rebound down and contract out. Which gets to the next part, which is contractility, which is how strong is your muscle and how well is the function of that muscle. And then we get to afterload. Afterload is the resistance ahead that you have to push against. And so preload, think of your venous return. So preload is where we're thinking about, gosh, if someone's dehydrated and they just don't have much volume, their heart's not going to work because the heart's not filled. So I'm going to give them volume and increase how much stuff is available to be in the heart. Contractility is where you're going to think about some of your vasopressors and really your inotropes to help make the heart squeeze better. And then afterload is things like trying to dilate blood vessels or trying to lower blood pressure so that there's less force and less pressure that the heart has to work against. So the 3 of those things together, preload, afterload, and contractility, are what's going to make up your stroke volume, how much your heart can squeeze with each beat. If we then combine stroke volume and we look at a heart rate, that is how you get to your cardiac output. And so per minute, how many heartbeats are happening with a given stroke volume, that is going to tell you how much blood your heart moves around and around per minute. And again, if there are questions, ask as we go. But these are the concepts that are literally going to dictate why we have the treatments we have for heart failure. Just because we're going to modify all of these things, modifying preload, modifying contractility, modifying afterload, and modifying the heart rate. All right, so what specifically happens in heart failure? So, heart failure, for one of various reasons that we listed out before, you're going to have decreased pump function. And so the pump is going to start functioning worse either because it can't squeeze as well, because it's now underfilled, it's now overloaded and has too much resistance to push against. Whatever the reason might be, the pump is not working as well as it's supposed to. And so now you're going to have a decrease in your cardiac output because you're going to have a decrease in that stroke volume. And so if the heart is still having a decreased stroke volume, you now have the piece of the heart rate's going to probably go up to try and compensate. But then we said over time, the heart going faster then leads to the heart not functioning as well. And so then you get buildup of fluid, and that fluid can then back up into the lungs, and then the lungs being full of fluid is what causes impaired gas exchange, shortness of breath, etc. So this is where that vicious cycle plays out. So some sort of insult, pump's not working the way it's supposed to, blood's not moving forward the way it's supposed to, and fluid is backing up to places like the lungs where it's not supposed to be. This is where we get to be super nerdy and talk about the neurohormonal response. So this is how the brain and the kidneys also then connect to the heart. And so the RAS system means the renin, angiotensin, aldosterone system. So it's a series of three different hormones. Renin sounds like renal because your kidneys make renin. And when your body does not have enough blood flow getting to the kidneys then say, what the heck? I'm going to make the body increase blood flow to me so I can get more blood flow. I'm the kidneys. I need blood flow to filter. I'm selfish. And so renin is going to then lead to the body to make two different hormones, angiotensin, which for those who have some critical care background, angiotensin is something that we'll give patients who are in refractory shock because angiotensin helps squeeze down the vessels to increase blood pressure. And then aldosterone is a hormone that tells the kidneys to hold on to more fluid. So hold on to salt, hold on to fluid, don't pee it out. And so the collective increasing blood pressure, increasing fluid retention is not going to go well for heart failure. SNS, the sympathetic nervous system. So when the brain starts to not get enough blood flow because the heart's not pumping right, the brain's going to lead to things like epinephrine and norepinephrine to be released, which is going to tell your body, hey, let's make the heart beat faster, let's make the heart beat stronger, and let's try and increase our blood pressure. And again, this is going to lead to a vicious cycle. So this is something else we're going to want to try and overcome. And then ADH is antidiuretic hormone. Similarly, when the brain's not getting enough blood flow, it releases this hormone. Antidiuretic hormone is actually the hormone that also controls your thirst. And so when your body thinks it doesn't have enough salt or doesn't think it has enough volume, it makes you thirsty, number one. So it makes you want to take in more fluid. And then antidiuretic hormone, as the name suggests, antidiuretic, it also works at the level of the kidneys to reabsorb water to make concentrated urine, so you're peeing out less. So it's going to make you want to take in more water and make it so that you're not getting rid of as much water, which again, initially is supposed to be compensatory because the kidneys are saying, I'm not getting enough blood flow, and the brain is saying, I'm not getting enough blood flow. But unchecked, these processes actually then become really harmful and cause increased stress on the heart, and you're going to precipitate to cardiogenic shock. So more about the pulmonary edema side. So specifically, if we think back to the heart, the right side of the heart, if it fails, isn't going to back up to the lungs. But when the left side of the heart fails, that's what's going to back up to the lungs. And so if for whatever reason you get increased pressure in that left ventricle, either because your afterload went up and you have more pressure to push against, you have fluid retention so that ventricle is extra full, or you have some sort of insult to the heart itself where it can't squeeze as well. When pressure starts to build up in the left ventricle, And then the next thing upstream is for pressure to back up into the left atrium, which really is not that muscular of a chamber at all, and it can't really compensate. And so then pressure backs up really easily into those pulmonary veins. And then when blood can't move forward out of the lungs, the fluid is then forced out into the alveoli. Those tiny little air sacs in the lungs fill up with fluid. And when those fill with fluid, you're going to have lots of other problems. And so this is where the actual shortness of breath comes from in the CHF patient, is the fluid filling those alveoli, because they're not going to be able to do gas exchange as well. And so they're going to both become hypoxic, which is going to make them short of breath, and they're going to become hypercarbic. They're going to retain CO2, and so that's going to also make them feel short of breath. So two different mechanisms for shortness of breath. And on top of this, when the lungs start to fill with fluid, the lung compliance goes down, which means the lungs are becoming stiffer. And so it's harder with each individual breath to really fully inflate those lungs, which is a vicious cycle, because if you're not fully inflating the lungs, you're not getting that fluid out as well. And all of this is going to cause increased work of breathing. And then when you're not breathing as well, gas exchange is worse. And again, you can see how this spirals into a vicious cycle. Now, flash pulmonary edema is really the big emergency piece that comes from this. And Hubert's asking a great question because he is getting to one of my big takeaways for this whole talk. We're going to talk all about CPAP, so hold on to that. Flash pulmonary edema, which again, all things in medicine, we have to rename every couple years so that it sounds fun. It's now called SCAPE, but very much can still call it flash. SCAPE, though, really describes the physiology that's happening here, which is to say sympathetic crashing acute pulmonary edema. So you get a big sudden surge of that sympathetic nervous system, and the body's releasing a lot of epinephrine, norepinephrine on its own. That's jacking up the blood pressure, it's jacking up the heart rate, and the heart is saying, what the heck, this is too much. The vessels are all clamping down, which again means that afterload is going up, so the heart has more pressure to work against. Blood pressure is going through the roof. That whole pressure system is backing up. Fluid is now building up rapidly in the lungs, and that is what that flash pulmonary edema is, of lungs go from being air filled to suddenly being pretty fluid filled. And this is what's going to ultimately kill that patient, is they're more or less going to dry drown, or without going underwater, but the lungs are filled with water, and that's what's going to kill them. Right heart failure is something that's also not great to have. When the right side of the heart is failing, this is where you see more of the systemic signs, which is to say, when the right side of the heart backs up, that then means the vena cava are backed up, which means fluid is going to build up everywhere else in the body. So this is your patient that has the big swollen pitting edema legs, where you go to check if the legs feel warm or cold and your handprint is left because they're just so fluid filled. JVD, for folks, the picture didn't actually come through. Bummer. For folks who've never actually seen JVD, if you have the patient slightly turn their head, you see a big prominent vein hanging out in their neck, that's not normal. Occasionally you'll see it back and forth with every heartbeat going up and down, because when that right heart drains, the vein briefly drains, and then that pressure builds right back up between every heartbeat. Hepatomegaly, if you feel abdomens enough to know when you don't feel a liver. And in adults, you really should not feel the liver below the ribs. And so if you go to push on someone's belly and you feel a big liver sitting there, that's likely fluid backing up to the liver. Ascites is fluid inside the abdomen. And so when you have pressure building up in all of those abdominal veins, volume fluid is going to leak out there. And then if right heart failure progresses enough, you're going to actually see a hypotensive patient, because if the right side of the heart isn't actually pushing blood forward to the left side of the heart, there's not blood to push around to the rest of the body. And so this person's actually hypotensive because of their heart failure, which is a really dangerous place to be, because that's then going to progress to cardiogenic shock. And so by the nature of shock, there's a hypotensive piece here. The person in cardiogenic shock, they're going to feel cool. them, unlike septic shock where they're going to feel warm because it's that big vasodilatory shock, the cardiogenic shock patient is cool because they're not having forward flow of blood. They're not getting warm central blood pushed out to the extremities. And to compensate, their body is clamping down as much as it can. So they're going to be cool. They're going to be clammy because all of those tissues are getting ischemic and they're stressing. So they're going to get diaphoretic. They're going to be altered because they're not getting enough blood flow to the brain. And then there's going to be a different approach to managing cardiogenic shock from just managing heart failure itself, and that we'll talk about here in a second. Um, there was an interesting case that came in off of an island community within the last couple of weeks that was brought into me of a relatively young woman in her 30s who had experienced a cardiac arrest, who actually has a certain disease called ARVD, arrhythmogenic right ventricular dysplasia. You by nature have right-sided heart failure from scarring, and is still really, really sick with a really, really big RV that's just causing really difficult to manage shock. So, right-sided heart failure progressing to cardiogenic shock is very, very hard to manage. But yet, there are definitely things that you can do to be making a difference for these folks. And the big thing, honestly, is recognizing that heart failure is what you're dealing with so that you can start these interventions early. And so, first and foremost, as long as you have a stable-ish patient or you have a bystander, family member, someone to get history from, like this for me, this is my list of questions that when I think I'm dealing with heart failure, I'm going to use to try and tease it out or to get a sense of just how symptomatic they might be. Like, this is where my brain's going. The really, really easy piece is to say, hey, do you have known heart failure? Because more times than not, the answer is going to be yes. That said, you might be encountering someone for the first time who does not have a known diagnosis. But first and foremost, if someone says to you, yes, I have heart failure, that in and of itself should put you into the direction of this is probably heart failure until proven otherwise. Combine that with if they also don't have a known respiratory history, it's really unlikely to have a COPD exacerbation or an asthma exacerbation if you don't have COPD or asthma to be exacerbated in the first place. So it's really easy to see shortness of breath and then treat with a neb. But we're going to talk in a minute that nebs are actually going to harm this patient. So if someone says, I have heart failure, I don't have known lung disease, this is almost certainly going to be heart failure, and that is the path you should commit to. Orthopnea, all these big Latin words. Orthopnea is the fancy way of saying when I lay down, I get short of breath. And so the way you can start to tease out this question is to A, ask if you lay flat, are you short of breath? B, the more subtle way that patients won't always realize is, hey, are you needing to sleep with more pillows at night than you normally use? Because that is the person, without realizing it, that's their way of treating their orthopnea. Is, yeah, I've actually been using like 4 pillows at night, or I've been sleeping in my armchair the last couple nights because when I sleep in bed, I get short of breath. The other piece with this is this PND, what's called paroxysmal nocturnal dyspnea. Again, really big words to say a really simple concept of I suddenly wake up gasping from sleep. Paroxysmal, sudden, nocturnal, night sleep, dyspnea, short of breath. So if someone's waking up gasping, short of breath from sleep, that is something to be thinking about. And then asking people, hey, do you keep track of your weight on a somewhat regular basis? And have you noticed if your weight's gone up? For folks with known heart failure, they are weighing themselves daily, and in some cases are in communication with their cardiologists and send in their weight on a daily basis because they're going to adjust their medications based on their weight. So asking folks, hey, what is your weight recently? And then the lingo is to ask someone what their dry weight is. The dry weight is something that when someone has gone and had a catheterization done on their heart, the cardiologist can then calculate what is the optimal weight for that person to be at based on how full their heart is or is not. And that is essentially their target weight. And so if someone is, multiple pounds over their dry weight or target weight, there is some fluid retention playing in here. Medication changes. Have you recently been up titrating diuretics because you're retaining fluid? Were you recently tried off of a medication to see if you could tolerate it, but now you're not tolerating it? But asking about missed changes there. One of the comorbid things, and this comes up especially if you have a dialysis center in your community, asking if someone has had missed dialysis recently, because that's going to cause a bunch of fluid to build up and accumulate that very quickly puts a lot of stress on the heart. Asking about chest pain, one of the biggest precipitators of a CHF exacerbation is ACS. So having a STEMI, NSTEMI, some sort of insult that has now made your heart sicker is going to cause the heart to not work as well. And then asking about their diet, right? We said that the Monday after Thanksgiving is one of the biggest spikes that we see in CHF presentations. And that's because there's a bunch of extra fluid, extra salts. The Super Bowl is another one. The day or two after the Super Bowl, between all the salty foods and all the beer intake, we definitely see a spike in CHF within those couple days. So asking recent changes to diet, asking if they just celebrated something recently, definitely is something that pushes you towards this might be a CHF exacerbation. In terms of the exam you're doing for this person, I mean, you're definitely going to do your big picture, vitals. We'll talk more in a second about the changes to see. But like your overall global approach, you walk in the room, you're looking at this person, you want to know what is going on. Look at their respiratory effort, look at their positioning, lift up their shirt and see if they're using a bunch of belly breathing, a bunch of accessory muscles. Is there sucking in of the muscles up here because they're having to work so hard? That's one clue. Looking to see if they're diaphoretic or not. A COPD exacerbation, short of, if there's diaphoretic because they're pneumonia and having a COPD exacerbation, COPD in and of itself should not really make you as sweaty. Sweaty is saying that there's a perfusion problem. And so if someone is short of breath and super sweaty, think CHF, because that is what's going to cause hypoperfusion and shortness of breath till proven otherwise. And then again, that dyspnea piece, like this can also be COPD, but the person who can only get out a couple words at a time and is diaphoretic and is posturing, that is someone that is definitely getting my worry of your lungs are full of fluid and you can't breathe. Now, a more focused exam. So definitely you're gonna, oh, here's my picture of JVD. You're gonna tune in on the lungs and you're gonna hear potentially multiple different findings for a CHF exacerbation. The textbook is going to tell you you're going to hear crackles, or if you want to sound extra fancy, you can call them rawls or rails, but crackles, that coarse, sounds almost like little bubbles, sounds like little bubble wrap that's being popped inside the lungs. That is because those alveoli are full of fluid and are collapsed, and the crackles you're hearing is when they take in a breath, it's those collapsed fluid-filled alveoli popping back open. So you're literally hearing those fluid-filled pockets opening back up with air. That is the nature of crackles. Wheezing is where this gets really interesting because there is this phenomenon called the cardiac wheeze, which is because of fluid and mucus buildup from the CHF, the airways also become inherently more narrow than normal because wheezing is just air moving through a narrowed airway. Whereas COPD and asthma, that narrowed airway is because of bronchospasm and tight muscle. This is because of fluid narrowing those airways. So it can be tricky that when you hear wheezing in someone who's short of breath to want to go the respiratory route, but don't be fooled if your person also has a bunch of edema in their legs and is diaphoretic and has a heart failure history. You are allowed to have wheezing in CHF as well. So wheezing does not necessarily equal COPD and asthma. Also, you might just hear diminished lung sounds altogether, which again, when the textbook tells you CHF is crackles and you listen and you actually hear nothing, while at first that might seem like, wow, I don't hear crackles, I'm reassured. I actually want you to go the opposite direction and say, oh God, I don't hear anything, I'm really worried. Because that means those lungs are so full of fluid and so collapsed down and so stiff that they're just not moving any air at all, which is a really poor sign that this patient's really sick and they're going to get really sick really fast. JVD, so this is that big distended jugular vein that's full of fluid right up the side of the neck. This should definitely get your attention. Someone with COPD alone, should not have a big distended neck vein like that. And then other peripheral things, right? The pitting edema in the legs, the extremities feeling cool, either pale or cyanotic extremities because they're not perfusing well. And then looking for delayed capillary refill. Again, poor perfusion. You're going to have at least 3 seconds or longer going back to those nail beds or wherever you check your cap refill. But that is going to be all these pieces, hopefully pushing you towards this is cardiac and I need to act quick. Other things, so vitals wise, hypertension is certainly the teaching points and the standard to look for, particularly if you're thinking about that flash pulmonary edema patient or that, SCAPE, the fancy name for flash pulmonary edema. That's that big sympathetic surge, I'm having flash pulmonary edema picture. But you also need to worry about the patient who's actually just gone over that tipping point and is now heading into cardiogenic shock land, which is to say, this is going to be the tachycardic patient, the normotensive to hypotensive patient. Like when someone comes in very edematous with crackly lungs and has a normal or low blood pressure, like that is the person that I am exceptionally worried about because they are about to try and die on you. Hypoxia, identify it, treat it. Oxygen is really easy to put on them, and we're going to talk more about CPAP very soon, I promise. And then the tachypnea piece. Again, look at that work of breathing. It's going to be subtle sometimes. Like they might speak in full sentences, but when they're not talking, they're breathing 30 plus times a minute. Next step, because you're worried about the heart, is going to be getting an EKG, having them on that 4-lead for continuous monitoring after. In terms of what you might find on the EKG, there's no one single marker to diagnose heart failure on an EKG. But findings that you may see that are concerning or will support your presumed diagnosis of CHF are going to be patterns looking for a left ventricular hypertrophy. That's those giant QRS complexes in your anterior leads, V2, 3, 4. Those QRSs start overlapping and running into each other to the next leads above and below. That's ventricular hypertrophy. If you see AFib or flutter, particularly if you see fast AFib or flutter, worry about that precipitating a heart failure exacerbation. If you see ischemic changes, right? We said ischemia can be an insult to tip into a heart failure exacerbation. Ischemia is worrisome. If you see a bundle branch block, whether it's new or known, this is someone who either has some baseline disease in their heart or has some new disease in their heart. But there's no one single thing to diagnose CHF on that EKG. Capnography is one of my favorite underutilized tools. Most cases here, you're going to actually see end titles within normal limits. That said, the person you're going to really worry about is when you do start to see them becoming hypercarbic, because if they're now retaining CO2, you're hitting that dangerous tipping point of impaired gas exchange, and they're going to get very sick very fast. So not the first thing to put on, but when you get to a place where like, gosh, what can I do next? Putting that end title on is going to be a great monitoring tool to trend that patient status as time goes on. So back to our kind of original discussion in terms of, okay, like we have this short of breath person. What are we thinking about? So sure, CHF is the nature of this talk, but distinguishing it from COPD and asthma. Again, if someone doesn't have known COPD or asthma, less likely to be the diagnosis. If they're edematous, they're diaphoretic, less likely to be the diagnosis. Pneumonia, if they're hypoxic and febrile with only focally crackly lung sounds over one lobe of the heart, one lobe of the lung, sure, you can think more pneumonia. But again, I'm going to talk about there's a common pathway to treat most of these things. Pulmonary embolism gets really tricky. PE, it's one of those kind of mystery diagnoses, particularly in the pre-hospital setting, that you really don't have many tools to try and diagnose it. So you just need to kind of suspect it's, the person who either has signs of a DVT, so they have one swollen, painful leg. It's someone who has a known clotting disorder. It's someone who's like coughing up blood and is tachycardic. smoking use, hormone use, like those are your PE risk factors. But I would still go the path of treat this patient symptomatically because you don't have thrombolytics or other things to treat PE anyway. So treat your patient's symptoms. Sepsis fits with pneumonia, but any other kind of sepsis is going to cause a shocky picture. But again, sepsis is going to be more of a warm shock with those dilated blood vessels, whereas CHF, progression to cardiogenic shock, is cold shock with clamped down vessels. Anaphylaxis is something you never want to miss. I'd hope that you can distinguish the two, but I will say even I myself am sometimes fooled by the sneaky anaphylaxis. If someone's having GI symptoms, if someone's having that rash, urticaria, hives picture, those are not really typical of CHF, so think more of an allergic reaction there. And then your ARDS, your acute respiratory distress syndrome. If someone's had recent lung trauma, if someone has sick lungs at baseline, think of another lung process that could be happening. But all right, for our last bit, we're going to get into the real meat, which is to say, I've told you all about heart failure. Now let's make sure we're set up to treat it once we identify it. So your initial priorities, it's the same as any patient. Go through your ABCDE, go through your March algorithm, whatever your tool is to make sure you're treating all aspects of your patient. Position of comfort for these folks is really important. I'd argue every patient should be made comfortable, but the person who's going to be able to likely sit upright and make a big difference in their breathing, the person who has appropriately fitting but maybe not super constraining seat belts, making sure this person can breathe and not feel like they're drowning in dyspneic is going to make a big difference in their stress level, which is then going to make a difference in their sympathetic level. So making sure they're comfortable and upright is great. Vitals wise, we've talked about 12 lead, we've talked about getting IV access early on to these folks is going to be great because we're going to talk about some of the different treatment options. And then targeting for a SAT here, like this is going to be for me, I like to target the mid 90s in these folks. This is someone that if you do over oxygenate them, it can actually cause some harm. And so if I know that someone's SAT is hanging out 94 to 96, I know I'm not too high. If they're maxed out at 100%, you can never go over 100%, but the PaO2, how much oxygen's in the blood, can start to skyrocket. So targeting that mid 90s means I know I'm in a place where I'm not too high, not too low. All right, CPAP. CPAP is more than just an oxygen delivery device. CPAP is the life-saving intervention for these folks. If you're ever questioning CHF versus COPD, if you're ever questioning, gosh, am I going to give this person nitrates? Gosh, am I going to give this person a neb? Gosh, am I going to do this, not do this? When in doubt, and I would say most of my colleagues, we are never going to fault you for putting CPAP on someone where you're unsure of what the cause is, or if you are sure, full send to CPAP. So what is CPAP going to do for you? It's going to do a lot. So it's going to give, as the name says, continuous positive airway pressure. So that positive airway pressure, one, it's going to help prevent those alveoli from collapsing, and it's going to recruit those collapsed alveoli. Recruit meaning it's going to help open them back up. So right from the bat, you're going to have improved gas exchange because you're now reopening all of those tiny air pockets in the lung. That's going to make the compliance of the lungs better, so the lungs are going to be much less stiff. It's going to increase your FRC, which is the space that just gas exchange is happening in. It's going to improve the VQ mismatch, so that's perfusion ventilation matching, which is if I'm sending blood flow to areas of the lung that are collapsed, the blood that goes there is not going to get rid of CO2, and the blood that goes there is not going to pick up oxygen. But if I now all of a sudden re-oxygenate a bunch of the lung, I'm going to get much more bang for my buck with gas exchange and make that matching better. You're going to decrease preload, and the way that works is by putting some positive pressure into the chest, into the whole thoracic cavity. We talked about the right side of the heart having such low pressure in that right ventricle, right atrium, and the vena cava, that by increasing the amount of pressure in the lungs and in the chest cavity, you have decreased blood return going back to the heart, which is going to help unload some of that stress. You also are going to decrease the afterload. So you're going to decrease the pressure in the aorta that the left ventricle is having to see every time it squeezes. And collectively, by improving preload and improving afterload, you're going to overall improve that cardiac output because your stroke volume will go up. And so your heart is going to be able to function better overall. So you are improving gas exchange and you are improving heart function by using CPAP. It is a win-win situation. So I'm here to hopefully sell you that the benefits here are exponential. Indications, really, if someone is short of breath and you think they have CHF or COPD, use CPAP. CPAP is the common pathway for both. Contraindications to CPAP, the big one that always gets talked about is either or two things are the truly altered patient. And the reason we worry about the altered patient gets to number two, which is to say the vomiting patient. So the worry with CPAP is because it's forcing air in with every breath that the person takes, is that if they vomit, it's going to increase the risk of them aspirating. So yes, that is a real consideration. That said, when you're in the spot of my patient is in distress, I don't have any other options, and they're altered because they're hypercarbic because they can't exchange gases, CPAP is more of a relative contraindication and still might be the right treatment for that patient. That is definitely a please call med control and let's talk about it. Because even though on paper it might say don't put CPAP on the altered patient, this might still be the right answer for this patient. So, yes, altered and vomiting are reasons that you should pause when you think about CPAP. But if you think your patient's that sick, please call and chat with us because we might still say, go ahead and try CPAP because this might still be what saves their life. The equipment itself, there are a couple different setups that exist out there. I have no stock in any of them, but just being familiar with what you have as your CPAP option. Some places carry just a straight up portable device inside of a small little briefcase. Some places there are inline systems that you just connect to an oxygen tank, and that's what's going to pressurize your system. So just be familiar with what you have and know how to use it if it's not something that you break out very often. The pressure to start at, again, it's going to depend on the system you have, but most systems have some sort of knob to dial up, usually starting at 5 centimeters of water, and then you go up from there. Five is, it's more pressure than what you have at baseline. But if you feel like you're not still seeing full improvement, you can go up on that pressure to help get more result. Monitoring for these patients. So this is going to definitely be have them on a pulse ox, have them on a 4-lead. This is where I, again, don't have stock. I'm a Zoll person. This is where I'm putting the Zoll on an auto refresh to recheck a blood pressure every 3 minutes because I want to know how they're hemodynamically shifting. And the biggest thing that I love to advocate for with CPAP, besides just using it in the first place, is actually facilitating your patient tolerating CPAP. And so analogous sedation is in the scope of practice, in the protocols in Maine to help facilitate CPAP use because patients don't always like it. They're going to try and rip it off. It is in the protocols that you can give things like fentanyl or benzos here to help them tolerate that CPAP. So don't forget the additional tools in your toolbox to help make this a useful treatment for these patients. The other big piece, nitroglycerin. Nitroglycerin here has a twofold mechanism. Nitro is going to dilate vessels, and it's going to dilate vessels on both sides, meaning it's going to dilate the veins and dilate the arteries. And again, dilating veins, this is decreasing your preload, so there's less volume going back to the heart to stretch it out, and it's going to dilate the arteries, and so you're going to drop your afterload, dropping your blood pressure, and there's less work that the heart has to do with every heartbeat. So preload down, afterload down means the heart has to work less hard with each heartbeat, which means the heart needs less oxygen use every time it beats. So the heart is less stressed. So again, we're in a much better place on so many levels. Indications, again, we're talking at this is a CHF talk, so CHF exacerbation, nitro is indicated. Contraindications here, there are some absolutes and some relatives. Hypotension, again, this is going to dilate the veins and dilate the arteries. If you're already hypotensive and you dilate the arteries, you're going to make them more hypotensive, so don't do that. And if you're hypotensive because you're in cardiogenic shock, That is the right-sided heart failure, or sorry, the right-sided STEMI patient. This is the teaching of never give nitro to an inferior STEMI. It's not entirely true. If someone has enough blood pressure, you can give them nitro. You just want to be absolutely sure you have IV or IO access first, because this person is so sensitive to preload that they might become hypotensive, in which case you want to be able to give them some fluid to augment that back. The other contraindication, recent PDE5 inhibitors. This is your sildenafil or Viagra or your Cialis. These folks already have a fair bit of effect in the nitrous system where the nitroglycerin is going to work. And so these folks usually become profoundly hypotensive when you mix the two. So avoid in those folks. And then severe aortic stenosis is a really niche thing. But if you happen to get that in someone's history that they have severe aortic stenosis, that is someone that you want to avoid nitroglycerin in. Routes and dosing becomes an interesting discussion. Sublingual and paste are options that you have available to you. I would love someday to see nitro drips hit the state of Maine, something I personally would advocate for. So anyway, currently though, sublingual or paste. I personally, cards on the table, I hate nitro paste. It's in my mind, it's much harder to control and regulate. And then if the patient absorbs too much, it's really hard, even when you wipe it off, to turn off the fact that it's already working. And then nitro has really, really good evidence for it, so use it. Nods to a couple other things that aren't as helpful and we don't really prioritize. So diuretics had a historical role in the pre-hospital setting, in the form usually of Lasix or furosemide. The issue with diuretics, and diuretics have even come out of phase of the initial treatment in the ED for these folks, is it's really hard to distinguish, is someone having their exacerbation because of a distribution of volume in the body or because there's excess fluid. And if it's just a distribution problem without being excess fluid, you're actually going to make the person sicker by giving them diuretics. Um, and then if they also have things like hypokalemia ahead of time and then you give them Lasix, you're going to make them a lot sicker. So if you're in a world where you can't check a potassium first, Lasix is another dangerous thing to be giving. And furthermore, there was some data that had come out that by giving Lasix, people were prioritizing Lasix before they were then giving nitro and CPAP. And so where nitro and CPAP are the much more proven and supported treatments, we don't want to delay either of those things. So diuretics have fallen out of favor. Opioids also were kind of an older school, like, hey, this person's short of breath, let's make them not short of breath. Issue being, like, you want these patients to have a respiratory drive. So you don't want to just give them morphine to make the shortness of breath go away, because that's not treating or fixing the problem. You just make them not feel short of breath, and now where their fast heart respiratory rate was their compensating mechanism, you take that away and they're going to get sicker. So again, this is, you need to give them the CPAP, you need to be considering nitro, actually treat the problem, not just masking their symptoms. So opioids out of favor. Bronchodilators, if you truly think this person has superimposed asthma or COPD, go ahead and try a neb, but gosh, you're very likely not needing nebs here. And there's only potential to make things worse, because what a nebulizer is, it's the opposite, or especially albuterol, it's the opposite of if we give someone metoprolol to make the heart less stressed, a beta blocker. Albuterol is a beta agonist, so you are literally doing the opposite of what we would want to do to protect someone who's having heart failure. And so holding off on nebs, unless you are truly convinced this person has overlapping COPD. And then cardiogenic shock is going to be a little different in the sense where I said we want to avoid causing extra stress to the heart. If we feel like we're at the point that the heart is so stressed that it is not working well, the patient's hypotensive, they're cold, they're not perfusing, A, don't give them nitrates because they're hypotensive and shocky and you're going to kill them. B, this is where you consider giving just a little fluid bolus to see if this person is truly preload dependent, in which case a little fluid might actually go a long way. Vasopressors here are something that you should be thinking about reaching for, which sounds very weird. And again, I would always empower someone if you're ever like, gosh, am I about to put this person on norepi when I think they have heart failure? Like, by all means, call and let's talk about it, but also just feel empowered to say, look, I thought this person had cardiogenic shock. The tool in my toolbox is to give norepi, really for heart failure leading to cardiogenic shock. Epi is a little better because it helps with the heart squeeze, whereas norepi works more on the vessels clamping down, which are already clamped down, but norepi will still work on the heart itself. Inotropes for folks in the critical care world or doing interfacility work. This is your dobutamine and others like milrinone, but dobutamine is really the standard here for cardiogenic shock. It fixes that inotropy piece, the squeeze piece. So we've talked about preload, we've talked about afterload, but that contractility and squeeze is where inotropes are really helpful. And then it goes without saying, but getting this person to a hospital. So heart failure therapy is just out in the world. This guideline-directed medical therapy is the combination of being on diuretics and beta blockers and ACE inhibitors, like trying to prevent all of these stressors in the first place. Cardiac resynchronization therapy is a fancy way of saying a pacemaker. And so the goal here is if the heart is not squeezing in unison between the two ventricles, we put in a dual chamber pacer to make the two ventricles squeeze at the same time to resynchronize the heart. Some of these folks, if the heart is too dilated and too stressed, they'll get ICDs, internal cardioverter defibrillators, placed. If it progresses enough, you then get into this world of VADs, which we'll give a quick nod to, but also recognizing the time we're at. And then if you're sick enough on that New York Heart Association scale, you actually become a transplant candidate, which that patient that came in from an island recently is potentially going to be a transplant candidate in their 30s because their heart is just so thick, so sick. And then eventually these folks get to a point of there's just nothing else to do. And so some folks end up being on palliative care, in which case symptom management is the focus of their treatment. VADs, very quick nod, but we have a whole separate talk on our YouTube channel from a prior VAD talk that was great. I would highly recommend you go to if you need a refresher on VADs. VADs are weird, right? Because VADs are different models, but mostly it's continuous flow. So the person's not going to have a pulse because it's just continuous blood flow going forward. Automated blood pressure cuffs likely then aren't going to work because there's no pulse to actually check a blood pressure. Your pulse ox isn't going to work because there aren't pulses and heartbeats. But you're going to look for, does this person look like they're in shock? Are they altered? Are they cold and diaphoretic? Is the device itself yelling and saying there's a problem? And the troubleshoot things that should always be on your quick list of troubleshooting a VAD is making sure it's not a battery problem. So make sure the battery's connected. If the battery's dead, put the spare battery on. The controller is the device itself. Make sure everything is connected to it. The drive line is what goes and attaches into the patient's body. Make sure that appears connected. And then the thrombosis piece is not something that you can deal with or fix. And in cardiac arrest, you still work it like it's a cardiac arrest. If they're in VF or VT, you still shock them. If they're unresponsive, you still do chest compressions. And then you should be calling the VAD center, AKA in the state of Maine Medical Center, as soon as possible to say, hey, this is what's going on. So yes, think about, do I need a STEMI center? Do I need a VAD center? The Heart Failure and Transplant Center here, at least in Maine, is all Portland for all of these things. But recognizing that sometimes we have folks log in from elsewhere, like make sure you're picking the right place for these folks. So putting things together, CPAP is your friend. Use it. There's excellent evidence for it. Start it early, start it often. We will never fault you for putting CPAP on someone that you thought had a CHF exacerbation. Same deal with nitro. There's really great evidence, specifically when they're hypertensive and you're worried about pulmonary edema. It's rapidly going to get your preload and afterload down. It's going to make a big difference quickly. Diuretics are out of favor. Opioids are out of favor. So again, CPAP, nitrates, make the diagnosis early, support their symptoms, get them on oxygen. But things that aren't going to help are delaying CPAP, giving too much fluid, nebulizers are not going to help and might only be harmful. And again, recognizing that wheezing as asthma and treating as such is going to be a pitfall. Missing ACS, like you identify the heart failure, but you miss the STEMI, not great. Waiting too long for CPAP because it's hard to recover when they do go unresponsive. underdosing nitrates. Don't be afraid to be aggressive here as long as their blood pressure is still good. And then monitoring these patients closely because they are going to make big swings in either direction really quickly. So back to our patient. I'm pretty sure I've sold you on the things that I would do here, but this person is approaching that SCAPE flash pulmonary edema world of hypertension, hypoxic, like this person's having fluid rapidly accumulating in their lungs. And so this is going to be a get them on CPAP, get nitrates on board, have access in case they go hypotensive, and get them to a hospital quickly. We've mostly highlighted the guidelines. I'm not going to go further here, but all of this to say CHF is everywhere. There are lots of people with it. It is a very common 911 call. It is a very common hospital admission. People who come into the hospital are going to come back because they are sick people. CPAP saves lives. I have no stock in any CPAP company. CPAP saves lives here. So please don't be afraid of CPAP. Pull out whatever setup you have. Make sure you're comfortable with it. Don't be afraid to use it. Nitro matters. But again, if you had to pick only one single thing, put these people on CPAP and then continually reassess them. All right, that's what I got. I'm looking through quickly what other questions there may have been. CPAP, we talked as we went. Will we get access to the recording and slides? Yes. These get posted. If you're on here, usually if you registered, you get the recording emailed to you. And then we have a YouTube channel that looks like Eric put the link in the chat to, where all of these end up at some point. Let's see. Hannah says, I recently had a CHF patient, 88%, struggling to tolerate CPAP, called for Versed due to concerns, anxious due to hypoxia. Gosh. This is where I wish I could control who answers the phone for med control all the time, and I don't. Um, yeah, this one's tough. Yes, I think how do I say this nicely? This is a time where I would empower you to advocate for the patient who's in front of you that the person on the other end of the phone is not directly looking at. This is something where in the emergency department we deal with this too, of like trying to deal with a consultant, whether I'm calling a cardiologist or I'm calling pulmonology, whoever it may be. Like they don't have the privilege of looking at the patient in front of them. And so if you feel like someone's not fully understanding the situation or the patient in front of you, like don't be afraid to say, hey doc, look, like yeah, sure, this patient might be hypoxic, but CPAP is the treatment they need. Like I need them to be able to tolerate it. Like don't, I would empower you to respectfully advocate for your patient and do what you think is the correct thing for them. Um, and as always, at least as if it's here at Maine Medical Center in Portland, but whoever else your EMS manager might be at other destination hospitals, like reach out, let us know about these when they come up because it gives us a chance to follow up with who may have taken that phone call. When you do let us know, if you are able to say, hey, this is who I spoke to, it makes it that much easier than us trying to figure out who might have been answering phone calls at any given time. But if there are ever issues or questions about online med control, please reach out to us and we can follow up because we are not perfect on the med control side of things either. And there's always room to improve. So as those come up, let us know. Admittedly, that is not the advice or recommendation I would have given. I definitely would have said, yes, treat them symptomatically so they tolerate their CPAP, but was neither here nor there. But yes, I think you did a great job identifying what that patient would have benefited from. All right. More upcoming education because education's my jam. We have next month couple offerings. One is on September 8th at 2 p.m., part of the IC education series. It's going to be a session on program design. And then next day on the 9th at 3:30, note the slightly off start time. 3:30 is going to be a talk on labor and delivery. Dr. Luke Roberts from our L&D team, who came and spoke a couple months ago about eclampsia and hemorrhage, is going to be coming back. It's going to be highlighting all of the stages of normal delivery, recognizing that that is the more common thing we come across than just the complications. So it's going to cover all the things of how to deliver a baby normally, but then also some of the complications that go with that and how to manage them. Then we jump to October, later in the month, another IC course on giving feedback. That'll be at 10 a.m. And then the next day on the 27th, our own Dr. Kate Zimmerman will be giving some sort of a medical topic. She has not exactly picked a topic yet, but whatever she talks about is bound to be another great time. Keeping on the radar, November 5, 6, 7 is going to be our second annual big in-person conference here in Portland, with some pre-conference stuff on the 5th and the main conference happening on the 6th and 7th. Registration probably in the next month or so coming out for that, so just keep your eyes open. We'll be sure to communicate. And then later in November on the 19th will be our own Dr. Bohansky giving a talk all about post-ROSC care. Basically, you got the pulse back, now what? So bound to be a really great talk there. And then continuing to work with our trauma team, because we'll be running trauma sessions every month still. We just don't have updated dates from them yet, but those will also go out once we have them to all of you folks. And yeah, as always, if there are topics that you do want to hear about and future things to get on the list, please let us know. Equally for the trauma side, they always like to hear about whatever cases you may want highlighted or featured there. So, reach out to us and we'll make sure the right people get recommendations of what to talk about, and we'll keep finding what we think are high quality speakers for you guys to make these worthwhile. So thanks for spending an hour every day with us. Continue to stay safe out there, stay warm. Hope everyone's having a good summer.